At the end of the randomized trial, there is really no difference. But then when you follow this patient for another 10 years, so now we have about 20 to 21 year follow-up, and by the way, we are still following this patient because these are the ones that developed type 1 diabetes when they were pretty young, so we can follow them for a long time. Now we have about a 50% risk reduction in terms of non-fatal MI, stroke, or cardiovascular death, which is statistically significant. So we think that there is this memory or legacy effect that tight glucose control from onset of disease is important for longer-term follow-up. And the same was true for the study in type 2 diabetic patient, the UKPDS. Again, this is, at the end of the study, the randomized trial, there was a statistically significant difference in hemoglobin A1C, but then at the end, they were superimposable for a number of years. And this is what I mentioned, this legacy effect. When you look at the outcome, in 2007, 10 years later, the all-cause mortality that was not statistically significant at the beginning now is becoming statistically significant. And the MI that was of borderline non-significant here now becomes more statistically significant. But again, this study characterized patient follow from the onset of the disease. Lately, over the last couple of years, there have been 3 large randomized clinical trials instead of what I see at least in my clinic most of the time. So patients that have type 2 diabetes, they are aged in their 60s, they have about 10 years of duration of diabetes, and these are all patients with high risk of cardiovascular disease. Almost half of them, they already had prior cardiovascular event, and the other half, they had other significant risk factor for cardiovascular event. And in these studies, the question was, can we really tighten glucose control with an A1C goal of 6 to 6.5, which is actually quite hard to achieve, and follow those for about 5 years and see if we can decrease cardiovascular event. And these are large studies, about 10,000, and the VA study was a little bit smaller, 2,000 almost. And basically, the answer is this: there was really no benefit of tighter glucose control in this patient population. And as we all know, treating diabetes, the lower is the A1C, and in the intensively controlled patient, they achieved this A1C, 6.3 to 6.9. There was much more hypoglycemia and much more weight gain, not exactly ideal side effects of treating patients with diabetes. But interestingly, in the ACCORD trial at least, there was also an increase overall death rate in patient more tightly controlled. And there have been probably 20 papers trying to find out what was this increased risk of death, and no one knows. Most of those were sudden death, and there is a big debate, is this because of hypoglycemia or not? Not completely clear. So in summary, the benefit of microvascular and neuropathic complication of good glucose control is well established. But the evidence for cardiovascular benefit is strongest for the type 1 diabetic patient, in which there is this potential legacy effect, in which the benefit of glucose control take a long time to occur. But for the type 2 diabetic patient, 90-95% of the population, probably there is a cardiovascular disease benefit in patients with shorter duration of diabetes and without a lot of atherosclerotic disease. But for the other patient population, very tight control potentially expose them to higher risk. And so these are the patients with long duration of diabetes, a lot of hypoglycemia, advanced atherosclerosis, of course, age and other comorbid conditions are important. And I'm not saying that we shouldn't treat them, but perhaps the goal shouldn't be an A1C of 6. Now, can we do something to prevent this really high risk of cardiovascular disease in diabetic patients? And I want to leave you with the results of this study, which is a very small study, but I think it is really intriguing. So this is the STENO2 study that was done in Denmark a number of years ago, and is a small study even for diabetic patient standard, 160 patients. They were randomized to conventional and intensive treatment. They follow for about 8 years, and then they were followed for another 8 to 10 years. And the treatment goal was a little bit more what we try to do in normal life, not just controlling glycemia, but also controlling blood pressure and lipids. Moreover, there were a number of interventions that were given to all the patients in the intensive therapy group and not in the patient with the conventional group. So diet and exercise were recommended for the intensively controlled patient, and I'm very happy to report you that Danish patients do not diet and exercise more than US patients. So basically they were told to do it and no one did it. But every patient in the intensively controlled group got an aspirin, got an ACE inhibitor, and then they got vitamins, etc. And these are the results, and this is the primary composite endpoint, which is cardiovascular, sudden death, MI, need for revascularization. And as you can see, in about the 8-year follow-up, there was a statistically significant and major reduction in primary composite endpoint by almost 50%. Disease instead is mortality. And when these patients were followed up for up to 13 years, there was a major reduction in mortality. This is total mortality, not just cardiovascular mortality. And when you look at individual events, there was a statistically significant and major reduction in the intensively treated group in death from cardiovascular cause, stroke, MI, CABG, PCI. So clearly, addressing glucose, blood pressure, and lipid controls can prolong survival and decrease this large cardiovascular burden that patients with diabetes have. Now, this is a small study done in Denmark in a randomized clinical trial, and of course, in randomized clinical trial, patients are seen by nurses, research staff on a regular basis, very different from clinical care. So the question is, we know what we should do for patients with diabetes, and are we doing and are we achieving these goals? And unfortunately, the answer is really not yet. So this is a couple of national survey in Haynes 3 in the 1990. This is the data from 2000, and this is the percent of the US patient with diabetes achieving A1C less than 7, blood pressure less than 130/80, and at this time was total cholesterol level less than 200. And the bottom line is that about 30% of the patient achieve this goal. And now when you look at what was the percentage of diabetic patients that achieve both glucose, blood pressure, and lipid control, was less than 10%. This is really somewhat disheartening. Now, it's interesting because when I superimpose to these studies the results from the BARI-2 trial, so this is again a randomized trial of patients with type 2 diabetes. Even in a randomized trial, less than 50% of the patients achieve an A1C of 7. And it's not that the investigators are not doing their job or the primary care physician are ignoring their patient. It is that to achieve an A1C less than 7 in a type 2 diabetic patient, you need to have a patient having a fasting glucose less than 120 plus a significant reduction in postprandial glucose. So for most of these patients, if they had diabetes for at least 5, 10, 15 years duration, we are talking about 3, 4, 5 shots of insulin a day. We are not talking just a pill. A pill will work for the first few years. Now, in a randomized trial, we are much better at controlling blood pressure and controlling cholesterol. But still, when you go to this combined outcome, even in a very aggressive setting, when you have a lot more resources that the healthcare system have, we are having less than 30% of diabetic achieving this goal. So really we have to work harder, smarter, newer drugs will help, but we have to both fight the epidemics of diabetes to have fewer of these patients, but also work much more aggressively in terms of patient and a huge component of treatment of patients with diabetes is, of course, adherence to the treatment. Our own study has shown that about the average type 2 diabetic patient is taking 10 different medications per day, and talking about adherence to once a day, to twice a day, to 4 times a day, adherence with insulin injection 2, 3, 4 times a day that are potentially immediately exposing the patient to the risk of hypoglycemia is really hard, and we have to work at this. And I think I'm going to stop here and have some time for comments and questions, and thank you for your patience.